And now we'll continue with target therapy, but change the target, not only inflammation, but we speak against cancer and following against dyslipidemia. We begin with Stefano Cascinu, and we speak about colon cancer.
Thank you, Giuseppe. Thank you, Professor Matera. I'd like to thank Professor Fabi for this kind invitation and for giving me the opportunity to share with you some information about the treatment with monoclonal antibody in colorectal cancer. I'm not sure that most of you will thank Professor Fabri for this talk, but I will commit fully to reduce your discomfort about completely different issues. But I think that this is my disclosure, sorry. I will briefly summarize some epidemiological data in order to put the context of the treatment of the disease. And what we have obtained before the age of monoclonal antibody in colorectal cancer, the results of monoclonal antibody, and some debated issues, and the future perspectives or future challenges, because I think that the most we have learned across this year, but we have most to learn much more in the future. The problem of colorectal cancer, unfortunately, in the Western countries continue to remain a major problem in our health systems because there is a slight increasing in incidence, even if there is a reduction in mortality. And it depends on probably on the screening programs and earlier diagnosis. Even if you look at the incidence, most of the patients continue to present with a metastatic disease at presentation, and most of them have a local regional disease, meaning with a positive lymph nodes. If you consider that this patient population have the risk to recur in the 5 years about 50%, you can realize that most of the patients have a metastatic disease diagnosis, and most will develop a metastatic disease across the next 5 years from diagnosis. There is some sign of an improvement in terms of results. If you look at the localized, regional, and distant, across 20-30 years, we registered an improvement in survival in all of these settings of patient, and probably it may be due to early diagnosis, screening programs. So probably in Italy it is not so relevant, at least to see an improvement in survival, because most of the regions in Italy have not a formal screening program. This is a really for our health system. This is an issue, a big issue. In adjuvant therapy and even for palliative treatment, if you look at the result in distant, meaning metastatic disease, we can realize that a slight improvement in survival by doubling the people living after the diagnosis, at 5 years after the diagnosis of metastatic disease. And this is what may due to the effect of chemotherapeutic drug, the old chemotherapeutic drugs, chemotherapy, and we can consider that most of the patients with positive lymph nodes that have a 50% of probability of recurring in 5 years, we can cure about 12-15% of them by adding to surgery chemotherapy. And this is the results of a metastatic disease, always by considering only chemotherapeutic drugs. And this was the survival curves for patients receiving only supportive care at the beginning of the 70s, or the 60s or the 70s. The majority, or probably all the patients didn't receive any kind of treatment for their metastatic disease, but only supportive care. And this is when we added 5-fluorouracil. I consider that fluorouracil, we are equal in age because we have the same age, and for about 30 years it was the only drug, I think, that with an efficacy in this disease. And this is with the effect of, by adding to fluorouracil, oxaliplatin or irinotecan. I think that is not the survival curve, the median survival, but the fact that at 5 years, about 10-15% of the patients were alive with the diagnosis of metastatic disease. So we can give some long, not a cure, but a long survival to this patient. At the end of the 80s, at the beginning of the 90s, a better knowledge of the molecular basis of tumors, including colorectal cancer, raises some information about the presence of molecular alteration in tumor cells, but even a better definition of the role environment in comparison with molecular alteration. Otherwise, the angiogenetic hypothesis presented by Judah Folkman, the first paper, the seminal paper, was in 1972, and when he hypothesized that transformed cells, tumor cells, may not become really tumors because it's not able to grow apart from 2 or 3 millimeters, but it is not able to metastasize. If there is not new vessels, new tumor vessels, this remains some tumor cells, but it's not really tumors. And the definition, this is Napoleone Ferrara, and it was we developed the monoclonal antibody. We defined the factor, the vascular endothelial growth factor, and that is the ligand for this receptor, transmembrane receptor, so that when stimulated can give some more chance to the tumor cells to grow, favoring angiogenesis, hematogenic angiogenesis, lymph angiogenesis, and by defining a microenvironment more useful for the tumor cells to grow. And Napoleone Ferrara, at the end of the 90s, developed a monoclonal antibody against VEGF. And bevacizumab, it was the first monoclonal antibody to be used in colorectal cancer, not one in colorectal cancer, because now there is indication for ovarian cancer. There is no probably evidence that there is the same effect, the same results in lung cancer. There is some evidence that it does not work in the same way of obtaining the same results. But this was a key point, at least for being involved in the treatment of colorectal cancer, because the first trial in 2004 showed for the first time that by adding these monoclonal antibodies to standard chemotherapy, we are able to improve survival significantly in terms of 6 months. It was the first trial showing an increasing survival over 6 months. And bevacizumab was able even to give a less probably improvement, but a significant improvement, even when we use in patients already pretreated with chemotherapy. So for the first time, there is evidence that a molecular target therapy was able to improve the results obtained with the chemotherapy. At the same time, there is another hypothesis. With the bevacizumab, we tried to interfere with the environment, while John Mendelssohn hypothesized that by discovering a family of EGF receptor, the epidermal growth factor receptor, these were 4 different transmembrane receptors, and if you remember, most probably know that HER2 is the target for the breast cancer treatment. Trastuzumab changed dramatically for most women with breast cancer, their outcome. And in colorectal cancer, instead, it was developed an antibody against HER1. And the hypothesis was that by blocking HER1, we are able to block the proliferation of tumor cells, so we have a favorable effect on the tumor growth. And the rationale was that by blocking this receptor, we are able to reduce proliferation, chemotherapy resistance, angiogenesis, and so on. And there was quite strange that in colorectal cancer, if you block with a monoclonal antibody, you have this effect. But if you block the intracellular part of the receptors, the TKI, TKI inhibitors don't work in the same way. It was strange because if you block the receptors outside the cell, you have the effect, but you block the receptor inside the cell, we have not the same activity. And this is it's quite opposite to lung cancer, for instance. So this is the same. Each tumor probably has a different mechanism, and we have to consider this when we design clinical trials or we ask for more information to molecular biologists. This is what the first trial showing was published. This was a phase 2 trial. It was published in New England because for the first time it was demonstrated that a monoclonal antibody given as monotherapy was able to produce a favorable results in heavily pretreated patients. So for the first time there was an evidence that we had a treatment that was able to change in some way the prognosis of this patient. But it was impressive that after these preliminary interesting and exciting results, we did not observe the same when in randomized trial we compare cetuximab plus or minus chemotherapy versus placebo in first line or in second line. And was quite surprised because why there is not effect in survival. And because we consider that we block EGFR, but in the tumor, colorectal cancer tumors are not all the same, or not all are equal, because some tumors present a mutation of KRAS, and the constitutional activation of KRAS makes ineffective the block of EGFR because the pathway is constitutionally activated. And we realized that probably we have not to treat the patient, all the colorectal cancer patient with this monoclonal antibody because we have to choose the patient with mutation of KRAS or no mutation of KRAS. If you look at the result, if you separate these different population, so two different populations of colorectal cancer patient, the results are coherent with the first trial. So probably you can use a monoclonal antibody, you can hit this specific receptor, but you have no exactly the pathway as it is activated or not and how. And this was demonstrated in further trials, suggesting that KRAS is a negative predicted factor for the activity or the efficacy of cetuximab. Why we are not able to select the patient candidates to receive bevacizumab? Because we have, unfortunately, no data supporting the use of molecular predictors. I was surprised because even in asthma or in respiratory disease, the biomarkers are very difficult to find. But in this case, we have a surprise because we have a target therapy, but we have no specific. And across these years, we have learned another lesson because not only KRAS or exon 2 and 3, but different mutation in different exons was able to predict the activity of cetuximab, but even other genes, RAS and BRAF. And if I considered all of these mutations, probably we can improve the results. Once again, we can improve the result simply by selecting the patient, not treating the patient that do not benefit because there is an activation of the pathway. But we are not able to understand why most of the patients not presenting a RAS mutation or an RAS mutation do not respond to cetuximab because we are not able to identify the real target. So we are using a target therapy without a target. And this is controversial. But the lesson was that colorectal cancer is a heterogeneous population, and we have two listed different molecular population, with a RAS wild type or with a RAS or a RAS mutation. And the treatment for these tumors could be really different, because for RAS mutated tumor, probably easy, we can use the antigenetic treatment because we cannot use an EGFR inhibitor. But for RAS wild type, we can use an EGFR inhibitor, cetuximab, panitumumab, we are exactly the same in reality, or bevacizumab, the antigenetic, because it works independently on RAS mutation. So we have to decide if it's more convenient to use in first line these two different approaches. And these were two randomized trials, and they're suggesting, this is a European trial, suggesting after 24 months, the survival curves differ and presenting an advantage for the first line with cetuximab. But it was quite unclear for most of us why we have to expect exactly 2 years before to observe an effect of the choice of cetuximab in comparison with bevacizumab. It was not clear. 2 years is quite long. We use one year before, because the median duration of treatment was 6-8 months, but the effect was 2 years later, which was quite difficult to explain. This is the American trial showing more or less the same data. And there is some information from preclinical point of view that suggesting that if you use an anti-VEGF agent and then an anti-GFR treatment, probably you preclude the effectiveness of anti-GFR. Probably by modifying the environment, because there is hypoxic and they change the metabolism of the tumor cells. Therefore, anti-GFR doesn't work. This is an Italian experience where we randomize after bevacizumab the use of GFR inhibitor or chemotherapy alone, and effectively, if you use immediately after bevacizumab an inhibitor of a GFR, you don't obtain the same result. You obtain a poor survival curves. So probably when we use a monoclonal antibody, we have in our mind that not only the use of monoclonal antibody, but even the sequence may be relevant. When you hit a specific pathway, there is maybe an effect in other pathway or even in the same pathway, precluding the effectiveness or the efficacy of the following agent. So probably when we use, I don't know in your experience it is the same, but the monoclonal antibodies may change dramatically the environment and the tumor cells. So this is not the same that you expected it to find. And this may be a relevant problem, at least for us. And another question, we can combine all of them in the first line because we have 2 different pathways and we hit different angiogenetic and tumor cells. The result was dramatically because we observed a worsened effect of the combination in comparison with the sequence. So another lesson for medical oncologists was that pay attention when you combine drugs and you hit different pathways, because the result could be surprising, but not in terms of favorable results, but in terms of negative results. And this is what we obtained when we added to chemotherapy. This is, you remember, it was the survival curves with the chemotherapy, and this is one by adding this monoclonal antibody. And once again, this is not relevant, the median survival, this is not. But it was about 30% of the patients and are still alive after 5 years. And I think that this is little, but it's a step ahead in the treatment of this patient. If you look at in the different ways, you can consider that now we are able to have about 1/3 of the patient still alive after 4 or 5 years. But there is several controversial issues and future challenges, because the price of this success, the onset of new toxicity, because in part some of them were unexpected. Increased risk of thromboembolic events, no, because anti-angiogenic agent works on vessels, so they can increase the risk. But hypertension was not clearly understood at the beginning. Or skin toxicity. And it was really a relevant issue because most of the patients present a skin toxicity that was difficult for them to be outside without. And this is probably the most important markers for predictive activity of bevacizumab, the sphygmomanometer. There is a patient that presents hypertension, probably this patient may respond to bevacizumab. So Ellis ironically said that the harvest of a decade of biomarker studies for angiogenic therapy, by including several PGF, VEGF receptor, VEGF soluble receptor, all concluded that probably if you measure blood pressure to the patient, we are able to have the idea that the patient could respond or not. And this is another controversial issue, that this is a skin toxicity. This is not easy to tolerate for most of the patient. But once again, if you consider that patient experience a severe toxicity, have the chance to live longer. but it's difficult to explain that the patient do have to tolerate a skin toxicity because you have the probability to live longer, not if you are sure, but you have the probability. And finally, there is some unexpected result. There is a 4 randomized trial assessing this monoclonal antibody in the adjuvant setting. We were not able to explain why all of them were negative. From a theoretical point of view, could be the best setting to test these drugs, but we are completely negative. And we are not using these agents in adjuvant setting. But probably for the future, there could be some innovative approaches that be suggested by the identification of not 2 different molecular populations in colorectal cancer, but 5 different populations. I'm really confused sometimes. You feel there is 5 different subtypes with different mutation, different prognosis, and probably if you look at, for instance, at this class of colorectal cancer, you have another unexpected surprise that was that the female specific pathways, the colorectal cancer is not the same in male and female. There is not in terms of differences in presentation, clinical presentation, but molecular basis. And probably we have to understand this. For instance, in female, there is an overexpression of VEGF. Probably bevacizumab could work much more here than in male. And we have to explore this, and even because some of these subgroups may respond to immunotherapy. But Professor Scagliotti will present data with this new monoclonal antibody, because in lung cancer, there is the evidence that there is a new tools for the treatment of the patient. In colorectal cancer, we are really at the beginning. And my optimism decreased across these years, because in 2009, in Nature, there was an optimistic view of this personalized cancer therapy gets closer. In reality, we are at the beginning of a personalized treatment, and I think that these sentences from Enrico Fermi sometimes may summarize my thought, because before I came here, I was confused about the subject, but I've listened to some lectures of the experienced, really experts. I'm still confused, surely at a higher level, but I am still confused. And I think that to reduce this confusion, we need to have much more data about the biology of this disease in order to understand what we do when we treat this patient with a monoclonal antibody that in reality we think that have the target, but probably this is not the target that we know. Thank you very much for your attention.
Thank you very much for the Bash lecture on review on colon cancer, and we open the discussion. Leo, you want?
Thank you, Stefano. You convinced me once more that of the importance of this crosstalk with other areas. And one of the reasons I expose my family, pulmonary family, to other talks is to learn. And what I learned, several things, and I'm very highly confused.
Oh.
But you gave me an important message that maybe Ian may go back to the first 2 lectures that were on our area. It is obvious in your reasoning that you are considering that the disease, in your case is cancer, changes over time and over the first treatment. And then you do a second step, and you consider the sequence, the biology and the sequence. This is something that we do not do. We do not do in our chronic diseases. And I think we don't do it in pulmonary, we don't do it in general in other chronic diseases. And I think that this is a very important message. The second is that all your studies are powered, of course, on survival. And the question now comes is what about quality of life, considering the limited, what weight does it carry in your clinical practice?
Oh, no, this is a key point. I think that the quality of life, for instance, for cetuximab, it was impressive when I discussed with some patients, because most of the patients present skin toxicity, and it was uncomfortable. It is very difficult to tolerate, because all people know what are you doing and what disease you have, because it's a typical skin toxicity. And they said that when in the third line, when we have no other possibilities for treatment, they tolerate very well this toxicity, and they do not modify the quality of life. But if you use the same drugs and we have the same toxicity as adjuvant therapy, when you have the idea that you are cured and you have only the risk to recur, the patient were not able to tolerate this disease. So I think this is a different settings where we have to assess the quality of life, and where the answer to these questions could be really different. In some of these trials where attempted the definition of quality of life, I don't know in your field, but in medical oncology it's very difficult to find a trial where the assessment of quality of life is not perfect, but almost.
Thank you very much, and we pass the next presentation. Professor Scagliotti.